in effect, what happens is that doctors and hospitals charge more people who are privately insured than the real cost of just covering their care. And then they use that more to shift that cost over to help cover the cost of those who are uninsured, known as uncompensated care, and those who are only have part of the cost paid, people on Medicare and Medicaid, that's known as undercompensated care. So, in effect, what's happening here, if you can look at this, is that in effect, people who are insured are paying about 130%, you can look at it this way, of the cost of caring for themselves. You know, people are always complaining, my heavens, I got this aspirin and the aspirin cost $100. That's outrageous. That's unbelievable. How can that possibly be? Right? Well, what's really going on there is that $100 aspirin is really helping to subsidize the cost of the hospital as a whole. Okay? And what happens is that extra amount over here gets shifted over in these sort of yellowish bars to make up the difference for covering the uninsured, those people on Medicaid, and those people on Medicare. Now, here's the point. To the extent that the government tries to shift costs through its general revenues, we have this fundamental problem that we've talked about, that government revenue rises only with the economy, but other government expenditures don't have the same productivity gain as food, clothing, shelter, and so forth. All right? Now, on the other hand, private sector cost shifting is in effect a hidden tax. And the key point about it is a tax that operates as a percentage of what is actually being spent on healthcare. So in other words, to the extent that what people who are privately insured pay for healthcare rises, so also does this hidden tax, this percentage that's taken off the top of it in order to subsidize those who can't afford or can't fully afford to pay for their own healthcare rises. So the great advantage of private sector cost shifting, there's some disadvantages in it, but the great advantage of it is it keeps up with what's being spent on healthcare in the private sector, which general fund revenues don't. Okay? Now, there is, however, a fundamental problem with private sector cost shifting. And that is that it isn't necessarily properly targeted. For example, you could have a hospital, maybe a suburban hospital, that sees a lot of privately insured suburbanites, but comparatively few people who are uninsured and comparatively few people who are on Medicaid. Well, in effect, that hospital is profiting from higher private payments from the privately insured, but not having to shift it all over in order to cover the costs of people uninsured and undercompensated. On the other hand, you can have other providers, like inner city hospitals, which may have many people who are uninsured, many people on Medicaid, but comparatively few who are privately insured. So they can't adequately cost shift. So here in Massachusetts, for example, one of the two major sort of safety net centers for people who are poor, Boston Medical Center, is facing a $173 million shortfall between what it takes in and what it has to give out. And there have been efforts to sort of plug that. $80 million in stimulus funds is trying to be spent to plug that. $64 million from an earmark in health insurance law is trying to help plug that. But there's still a gap of $1 million. And on a national scale, there are all sorts of things that are done. There are so-called DISH payments, or disproportionate share payments, that are supposed to go to hospitals that fall into this category. And there's all sorts of sort of Band-Aid patchwork quilt ways to try to use general fund revenues generally to try to make up this gap. So we have this advantage of private sector cost shifting that is based on what it it grows with what is actually spent on healthcare in the private sector. But we have this disadvantage that it's not private, it's not well targeted. And then we have the additional problem, which is specifically true of people who are uninsured, and who show up at the hospital emergency room, that these are people who probably are only showing up when they have a serious illness or injury, so they're not getting preventive care, they're not being seen by primary care providers. They're showing up at what originally was intended to be, a trauma center for automobile accidents and gunshot wounds, and they're showing up because Johnny has a sore throat or, the flu. So it's an inefficient expenditure of resources, and it's also not necessarily well treating the people who are uninsured because they're not being caught, the circumstances that require treatment are not being caught early. So, what is the solution? Well, there's actually a fairly straightforward one. Because we recognize that when subsidies depend on general tax fund revenue, it can't keep up with healthcare costs. What we could do is to capture this private sector cost shift, which is already going on. And instead of having this cost shifting occur at the level of the provider, have it occur at the level of the insurer to make sure that people who are uninsured get insurance. Now, what do I mean by this? Well, the fundamental point, before we look into the specifics of it, is that if we go back to this chart and showing what's going on here with regard to providers, they need this private sector costing, these extra funds, in order to cover uncompensated and undercompensated care. But if you provide premium subsidies, let's just focus right now on the uninsured. We'll come back to Medicaid and come back to Medicare. If we focus on the people who are uninsured, if we wind up giving premium subsidies to them so that they can get insurance, which is essentially what's been done in Massachusetts, what that means is that providers should no longer have to need that extra funding to cover people who are uninsured, because they'll now be insured. Okay? They'll be in theoretically this category as opposed to this category. And if that insurance that they're getting provides reimbursement rates to providers that are commensurate with what's generally provided under private insurance, what it means is there'll be corresponding less of a need for some of this private sector cost shifting. Okay? Now, so what if we did the following? What if we had actuaries estimate the cost of providing these premium subsidies to people who are uninsured for basic health insurance? And it could be, as it is in Massachusetts, sort of a sliding scale. If you're below a certain percentage of the poverty line, you get a full subsidy. If you're between that and some higher percentage, you get a sliding scale approach. Okay? And then estimate the expected total of what everybody's going to be spending in private insurance premiums, say during the next calendar year. And then, it's more complicated than this, but basically calculate the ratio. Okay, what is the ratio? What percentage of this equals this? Okay, what percentage of the total cost of private premiums is needed to cover the cost of the premium subsidies? Now, these figures are arbitrary for arithmetic simplicity. This would not be accurate what it would come out with. But what you would do then is suppose that rate turned out to be 10%. Then, when the program was implemented, when insurers and self-insured entities began paying claims, what they would do is they would withhold that percent. So if there was a procedure that was billed at $1,000, the insurer would actually pay the provider only $900 and withhold the $100. That $100 would be going to cover the cost of the premium subsidies. And the trade-off for the providers would be they would be getting lower compensation, but they would no longer need to cost shift from that compensation to cover uncompensated care. That's the fundamental trade-off. Now,